I've never got a chance to train with Divya sir, but I would say that I'm in the range. And Shyam also thanks a lot. I work at Whitefield Manipal Hospital, and I'll be speaking on the SCR. So thank my teachers again, including Dr. Mihata, for giving all the whatever we know about the SCR to us. So now Clement sir has already gone about the anatomy and the capsule. So we understand the capsule is a very important structure, and the capsule is a very thick structure, and it's a very important contributor to stability. And we also know there are different considerations in irreparable tear, like tendon retraction, inelasticity, muscle atrophy, and fatty infiltration. So once we decide that this particular patient is fit for SCR, so I would say the indications are quite simple. That means if it is a like grade 3, that is a patellar retraction. So this is a patellar retraction of grade 3, it has gone up to the glenoid, we know that we can't repair it. And if it is, then it should not involve the glenohumeral joint. That means glenohumeral arthritis should not be there. And fatty infiltration can be compromised. Even stage 3 fatty infiltration or a stage 4 fatty infiltration, we can do it. And we have found that this fatty infiltration can be reversed. So coming to the SCR, so Clement sir was saying that multiple effects, spacer effect, trampoline effect, and the force coupling effect. I would say that more than the other effects, the force coupling effect is the most important key in the success. So how did it start off? In 2012, Dr. Mihata did a biomechanical study, and he showed that if you do capsular reconstruction with the fascia lata, he found that there's a decrease in the subacromial contact pressures, increase in the acromihumeral distance, results in glenohumeral compression pressures. And he found excellent results, and this was the results in 72 shoulders, excellent range, and post-operative scores improved quite significantly. Retears were only 5 and 72. So then here I was, because we have talked about the fascia lata, and I would try to emphasize more on the fascia lata, because I try to show that the outcomes of the fascia lata are much better than the other techniques. So when we look at the fascia lata, when compared to the dermal allografts, what we find is, so this is the fascia lata, excellent results. That means reversal of the shoulder paralysis, less retear rates, 5% is the retear rates, increase, you can see the increase in the range, going from shoulder paralysis to almost 147 degrees. And then we also find a significant increase in the ACS scores. So then when we compare this to the dermal allografts, let's see what is happening. The dermal allograft is not available in our country, but we find that definitely there is an increase in the ACS scores, but higher retear rates, and there's not much increase in the significant increase in the AHB. Coming to the newer results, 2020 Burkhardt paper shows excellent results with the dermal allografts, and this is a Dennard paper 2017, good results with dermal allograft. But when you compare it, these are the takeaways. So this is another dermal allograft paper showing that when you do a dermal allograft, there's definitely increase in the ROM, HD and all that. But the systematic reviews definitely show the fascia lata is much better. Coming to biomechanically, when we use the fascia lata, so what happens? What should we remember when we use a fascia lata, when we compare to other thinner grafts or dermal allografts? What we find is the most important takeaway is the thickness of the graft. Minimum thickness should be 8 mm in the fascia lata. And another important thing in the biomechanics is we do a side-to-side repair. You can see there's a side-to-side repair here, that is the remnant cuff will be here as well as here. So if you do an anterior as well as posterior side-to-side repair, too much of stiffness is there. So whenever using the fascia lata, you should only use a posterior side-to-side repair. Anterior is not required. At the same time, when we're using a dermal allograft, we have to use both anterior and posterior because the elongation of the tendon. So that's an important thing to remember. So coming to graft thickness, I already mentioned that minimum 8 mm graft thickness is ideal. Coming to shoulder positioning, when you're using the fascia lata SCR or an SCR rather, you should be around 15 to 45 degrees the average shoulder abduction which is required when you do it. And some cardinal questions. So come to us when we do an SCR. Do the graft heal? Definitely we have MRI studies, Doppler studies show the grafts do heal. Does a fatty infiltration reverse? Yes, there are documentation that fatty infiltration also reverses at least by 1 or 2 grades. So do allografts or dermal allografts heal? Yes, there are some papers out there showing that dermal allografts also show some healing. So coming to graft harvesting. So in graft harvesting, the most important thing would be, so minimally invasive graft harvesting has better results.
So how do we do? The patient is already in lateral position, so we expose the facial lata and we do an intraoperative measurement how much of defect is there, and then I would either double it or triple it, so much of length and the width has to be taken, and then we do it. So this is the graft harvesting, you can see that, and it should be taken like the average. Where should you take it from? It should be just over the GT area, around maybe 5 centimeters proximal to the GT and maybe around up to 10 centimeters distant to GT. This is where you can take it. So I'll go on to the other things. So now there have been modifications to increase the thickness and the rigidity of the facial lata also. This one paper which shows that when we put a polypropylene mesh, so it increases definitely the stability of the graft. So this is another modification which has happened to the facial lata. So this is one particular case we had. So the patient came, is agriculturist, came with a history of injury to the right shoulder, fall 6 months back, taken physiotherapy, not responded, pain continues. So that is his main problem. The pain is not relieving, and he had a minor power loss, okay, that is 3+ power, that is his findings. So full can test positive, empty can positive, operand was positive. Tenderness, these are the biceps, subcoracoid and coracoid area, they had tenderness. So this is range, excellent range. And this is the MRI, shows a significant retraction. You can see that the anterior portion is retracted, but the posterior is like a grade 2. So anterior supraspinatus is in grade 2, so grade 3, and posteriorly it is like infraspinatus is in grade 2 retraction. So this is grade 2 fatty infiltration, and this is the diagnostic arthroscopy. So we do a diagnostic, I can see that the biceps is there. So I do a combination. So I modified the SCR. So Clemenson just showed that okay, he does the biceps. So I incorporate the biceps into the facial lata when I do the repair. Why? Because it increases the rigidity, increases the thickness of the graft. So now, so that is the biceps. You can see it is intact. I will run the videos faster. So after all the releases, I'm trying to take it back. So I realized that okay, I'm not able to repair it. So then I'm planning for a facial lata now. And then the first step is to isolate the biceps and stitch on the biceps. And then I start with the glenoid anchors. With the biceps, you can see there. I'm cutting the biceps and doing the bicep fixation anteriorly. Then this is followed by the glenoid anchors and the medial row anchors, and then you measure. So you can see the biceps being fixed there, and this is followed by the measurements and the remaining fixation. So the facial lata is taken out. This is how it is. You prepare it, and this is the technique of suturing it. So this is what exactly I do. I use a triple loaded anchor in the anterior part. So there's a triple loaded anchor there, and you can see that I use the biceps here, and another suture will be passing directly to the cuff here. And the remaining would be used, one more suture will be there, and that will be used for the fascia to come in. So this is how it's being shuttled inside, and we use a split 10 cc or 20 cc syringe depending upon the size of the graft. So here again, this is the final suture. You can see the suture pattern. This is how the sutures are passed and patterned, and I kept the graft inside, and the remaining sutures are in place. So this is the final suture construct. You can see that this is cross. This is how we do it. And most important thing I was saying, the side-to-side repair. I do a posterior side-to-side repair, and that is very important. Multiple passes in the side-to-side would be great. So this is I use a spinal needle sometimes to do it, and sometimes use a scorpion also to do a side-to-side. So this is the final results. Patient got excellent results, 5/5 power, return to agriculture activities. So my take would be that facial lata SCR is a great choice whenever you have the anterior and the posterior force couples ready. That means subscap should be, even if it is torn, it should be repairable. If we can repair it, definitely we can anterior as well as posterior force couples. Then what I have added in my practice is deltoid strength should be good. So we can check the deltoid strength. And second is another thing I recently added, because what I noticed was these patients still find it difficult to do a forward elevation. So I started doing the external lag. The infraspinatus might be intact, but still I feel that external patients are not doing that well when we do an isolated SCR. So whenever there's an external lag, lower trap should be added along with the SCR, and that gives excellent results. Thank you so much.